This video shows you how to do pre-procedure CT planning using the Redo TAV app. For index TAV is ACURATE and second TAV is SAPIEN 3 or MyVal. When you click Redo TAV CT planning on the home screen, first you will get the overview of all steps you need to do. The CT acquisition protocol can be the same with routine pre-TAV assessment. It's recommended to obtain an ECG-gated multiphasic function CT that covers the entire cardiac cycle, with ideally 20 phases, a minimum of 10 phases. The mid-diastolic phase generally has fewer artifacts, allowing for better assessment of the prosthesis reflex and commissure alignment in most patients. The end systolic or end diastolic phases could be used as alternatives. The first step is index TAV and measurement. If a pre-index TAV CT data is available, select native valve morphology and the severity of calcification, and identify your patient index TAV type and size. And then you will get the fundamental information of the valve. Please keep in mind that this light blue eye mark is a link to some detailed information. The leaflets of ACURATE starts at the bottom of upper crown and ends up to the commissure tab. On the next page, select the index tab failure mechanism and assess commissure alignment. Open your patient CT dataset on CT software. We can use any software, we just need 3D MPR, multi-planar reconstruction module. We are now at the end diastolic phase, 0% cardiac phase. So first, we need to identify the best cardiac phase to analyze with less artifact. So move to the systolic and mid-diastolic. Generally, mid-diastolic around 70 to 85% is the best cardiac phase with the less artifact. And also you can see the leaflet. Here is the entire structure of the ACURATE. And assess commissure alignment in the orthogonal view, which refers to the relations between the native aortic valve commissure and THV commissure tab. The commissure offset is directly measured using an angle tool with the limit aligned with the native commissure of the RCC and LCC and the THV commissure. In this case, the angle is 36 degrees. So select moderately misaligned and perform the measurement of area and perimeter. These measurements will be used for second TAV sizing later. We can also understand how much the index TAV is underexpanded at this point. For ACURATE, 2 levels require assessment. The level at the bottom of upper crown and not 1. Here it's the bottom of upper crown level, making sure the MPR is precisely orthogonal to the valve. And measure the area by tracing the center of the stent frame because of less blooming artifact. So please remember that down the window level is helped to see the stent frame clearly. And save your measurement to the report system. And now move to the node 1. Make sure you are right at the node 1. After we're drawing the measurement, Please fill in the areas and perimeter you measure in the app. Step 2 is identify your patient coronary risk level, which is defined as the lowest level of coronaries in relation to accurate reference level, as you can see on the app. On the CT, we are now at the inflow level, so scroll up the plane, and first you see the bottom of RCA, where just below the top of the upper clamp, but above the bottom of the upper clamp. And next, you can see the bottom of LCA, which is above the top of the upper clamp and just below the commission tab. So on the app, select the bottom of RCA and LCA level, and the app will automatically identify the coronary risk frame. At the step 3, once you select a second tab, you will get an idea about ideal or acceptable level of neoscat frame, NSP, which is defined as the top of the neoscat. For MyVal or SAPIEN 3 in accurate combination, it is multiple levels between the bottom of commercial tab to the top of the upper clamp. This is because the leaflet nadir of accurate starts at the bottom of upper clamp. So to treat the degenerated leaflet, we need to implant a leaf at the top of the upper clamp. But at this implant position, we would admit some degree of leaflet overhang. If we implant higher, like bottom of commercial tab, there would be less leaflet overhang, but it can increase the risk of coronary obstruction. Based on such understanding, you would choose neoscat frame where you would like to implant. Here is some guide how to proceed from here. We would recommend to assess at all possible neoscat frame and save the summary report for each level. As second tab sizing and the coronary risk may change according to the neoscat frame. The lowest neoscat frame, which is bottom of the upper clamp for accurate, should be used only for pure aortic regurgitation, since at this implant position, a second tab will not pin out the index tab at all. Last but not least, when the reason for Redo TAV is palpebral leakage, please make sure the second tab will cover the annulus level. So, I will start with bottom of commercial tab. The neoscat plane at this level will be above the coronary risk plane, both coronaries in this case. So we need further coronary assessment. But remember that a balloon expandable second tab can expand index tab, which means reduce valve to aortic distance, increasing coronary risk. So we need to determine the second tab size first. Step 5 is in vivo CT sizing. For MyVal or SAPIEN 3 in accurate combination, it's recommended to use the average area at the two levels you measure at the step 1. On the app, the two levels will be automatically selected. So please make sure the numbers are correct. And if you would like to, click the bottom of Include Perimeter and click the Calculate. Then you will get calculated average area, perimeter area derived diameter, perimeter derived diameter. The app cannot suggest sizing at this point due to the FDA regulation. So you will need to choose the second TAV site based on your CT measurement. Here has some guide how to choose site, and here you can get the IFU table too. For this case, I will choose size 20 SAPIEN 3 and move to coronary risk assessment with the size you chose. ACURATE is a unique valve that demonstrates different dynamics to balloon expansion, depending on the location. In bench test, below the bottom of the upper clamp, further expansion of ACURATE is observed with balloon expansion. But above that, expansion beyond the commissure pulse is not confirmed. Given this, when assessing coronary risk, it's recommended to measure the distance from the commissure pulse above the bottom of the upper clamp, and below that, the distance from either the virtual circle of the second TAV size you chose or the index TAV stent frame, whichever is outer, and identify the narrowest VTA distance in the zone from the neo-scat plane to the coronaries. When the neo-scat plane is above the ST junction, please don't forget to assess VT-SJ. In the app, the relationship between the neo-scat plane and each coronary is automatically identified. When the neo-scat plane is above RCA or LCA, the next assessment is the relation between the neo-scat plane and ST junction. I recommend to assess RCA and LCA separately and fill in the app. Let's start with RCA. Now we know the RCA is between the commissure pulse, commissure TAV, and the upper clamp. And we can see the stent pulse. So I'm drawing the virtual circle throughout the stent pulse and brings the plane and the neo-scat plane, the bottom of the commissure TAV, and assess the relationship with the ST junction, which is just below the ST junction. So I measure the valve to aortic sinus at this level from the stent pulse circle to the aortic sinus. Save the report and scrolling down to the coronary. Here I measure the VTC from the stent pulse and save to the summary report and fill in the app. The next is LCA. So align the LCA side and bring back the plane to the neo-scat plane. Assess the relationship with the ST junction, which is below the ST junction and just the coronary level, and still above the upper clamp. So I measure the VTC from the stent pulse and save the report and fill in the app. Although this case has a neo-scat plane at the bottom of commissure TAV is above the coronary risk plane, the narrowest VTA values for both coronary are greater than 4 mm, so the risk to coronary is constant as well. You will get summary report of 3 pages, which include animation representing the relationship between the neo-scat plane and both coronaries. You can take screenshots and also import these reports into CT software summary report, such as 3 mentioned. Next, let's assess the different NSP level. So click this button and you will come back to the step 4. Choose the nail scut plane. So select the at the top of upper clamp. The nail scut plane at this level will be still above the coronary disc plane. So you need further coronary assessment. And do the same step for in vivo CT sizing. For ACURATE, we use the same two levels, so the size generally the same. And move to the coronary risk assessment with the size. Follow the same methodology. Now you notice that the nail scut plane at this level is below the LCA. So in the app, that's automatically identified and you don't need to assess the LCA side. So assess the RCA side. First bring back the plane to the nail scut plane, top of the upper clamp. First assess the relationship with the ST junction. Now this nail scut plane is below the ST junction and just at the coronary level and still above the bottom of upper clamp. So VTC will not change. So we can just use the VTC measurement we already have done. Fill in the app. So for this implant position, the nail scut plane at the top of the upper clamp is below the LCA, but above the RCA. And the nowest VTA for RCA is greater than 4 mm, so risk to coronary is considered as low. And you will get the summary report of 3 pages. If available, the information of pre-index TAV CT can be gathered at step 8. This information can help your planning more. Based on all information, please consider the feasibility of Redo TAV and where implant position is more suitable for your patient. I hope this video helped your planning. Thank you.